talk about racism as an addiction, racism as trauma. And the reason I want to drop the concept of racism into those two frameworks is because as behavioral health professionals, we already have a skill set and a competency in approaching the design of systems to care for people with addiction, in approaching the individual care for people with addiction, in designing and delivering trauma-informed systems. And so if we can understand racism in these two frameworks, then we don't have to start from scratch in trying to design racism-informed healthcare systems, racism-informed behavioral health services, racism-informed addiction treatment services. We can use what we already know about those concepts, the guiding principles we have for designing those systems, use those skills to and that knowledge to drive equity in the services that we're providing in addiction and behavioral health settings. And so I like to start with this quote a lot. And if you came to part 1 and part 2 of this 3-part series, you may have seen this quote before. If you didn't, if you weren't able to make it to part 1 and part 2, definitely go back and watch the game tape, as they say, because those are definitely laying the foundation for today. But today stands alone. Addiction to me is the epitome of disconnection. In theory, recovery entails being connected again. And so when we look at the definition of recovery, I think too often the concept of recovery from addictive disorders is complete abstinence from whatever that substance is or whatever that behavior is. And let me actually step back before we talk about recovery and talk about the definition of addiction that I'm using today. So the definition of addiction that I'm using today is a broad concept, which is continuing to engage in some behavior despite negative consequences outweighing the positive benefits. And I want to put a real emphasis on the last part of that sentence, negative consequences outweighing positive benefits. Because as human beings, we don't do anything compulsively that doesn't have benefit. And part of harm reduction, part of motivational interviewing is understanding what are the benefits that that behavior or that substance use is bringing that person, so that we can try to get those benefits through a different conduit, or so we could try to get to the root cause of why they need those benefits. So to give a practical example, a person who has a risky alcohol use pattern and untreated anxiety. The benefit of that risky alcohol use is that it's helping to treat the anxiety, even though the negative consequences, once that turns into an alcohol use disorder, begin to outweigh the benefit of treating that anxiety. If we don't find another way to treat that anxiety, our hopes for getting that risky alcohol use pattern to something safer or complete abstinence, depending on that person's goals, is stymied, because we're not addressing the benefit that that risky alcohol use is bringing that person. And so I'm spending time on that because when we talk about racism as an addiction, so if the definition of addiction that we're using is continued engagement in a behavior despite negative consequences outweighing positive benefits, we have to look at the structures and systems and people who benefit from racism. I think we can look at health disparities, and we can look at education disparities, and we can look at wealth disparities, and we can look at legal system disparities, and we can look at wage disparities, and we can know that racism's negative consequences are abundant. The question is, are we at a point in time where we believe the negative consequences are outweighing the positive benefits of power and structure and creating haves and have-nots? I would say that the answer is yes. And if we can get to that point of understanding what the positive benefits of racism are, believing that the negative consequences of racism are outweighing the positive benefits, then we can apply what we know about addiction to building racism-informed treatment systems and organizations. And so if addiction is the epitome of disconnection, what does racism do? it disconnects us, right? This is the next parallel. Disconnection drives illness and health impairment and morbidity and mortality. And racism, we know, drives all of those things through disconnecting. We are pack animals, and one of our basic biological needs, we'll get into this in a little bit, is being part of a pack, the connection, the nurturing, the safety that comes along with that. And the way we use racism and discrimination is to kick people out of the pack. Now, I'm not going to stand up here and talk for an hour and a half without putting you all on the hook for being interactive. We're going to use the chat box for that. And so let me just know this chat box is working. Let's see, what's a question I can ask? Let's see who's in the audience. What is your professional role and where in the world are you joining us from? Let me see the chat box. I just want to make sure, one, that it works. 2, that you can find it and that you have it open so then we get to our interactive part. And 3, peer support from Ottawa. Hey, Stephen, making sure you're not checking your email while I'm up here doing all this talking. Oh, I can't read this fast. Sheila, okay. Oh, clinical supervisor, court administration, clinical practice, case manager, Milwaukee. Hey, Monica, ATL, I'm in Decatur. Nassau County, Florida, Ray, Michelle, and SATTC, Erica. Oh, okay, y'all are amazing. My eyeballs, like I literally have to get my glasses out to be able to read all of these going fast. So now I know the chat box is working. So when I start asking for questions and impact, and input, I don't want y'all having me out here on a limb by myself being all quiet, acting like we have technical problems. So here's what I hope we'll accomplish together over the next now hour and 20 minutes. Upon completion of this activity, what I hope you'll be able to do is describe the parallels between racism and addiction. So I kind of started getting into that a little bit in the introduction. I want us to understand racism as a trauma and understand the impact of racism on health. And that's where we'll actually spend the bulk of our time today after we lay some foundation. If we can understand racism as trauma, then we can apply the evidence-based strategies that we use to treat addiction and substance use disorders and that we use to design and deliver trauma-informed care. We can use those skill sets to mitigate the effects of racism on health and healthcare. And as we get to the end of this time together, I'm really going to be asking you all to be putting ideas in the chat box for how we can move forward very concretely today, something I will take away today and do, applying my existing trauma skill set, applying my existing substance use disorder skill set for how we start to address racism to resolve the inequity that we see in development of addictive disorders, access to treatment for addictive disorders, retention in that treatment, as well as the outcomes. And then finally, I want us to be able to initiate conversations about racism and health, knowing that the two are inextricably linked. So we have people from all over the country in all kinds of different roles, which is amazing. I want to start with this concept, substance use disorders, and so I should say substance use disorders and other mental health disorders, because substance use disorders are mental health disorders. This kind of false separation of these that we have in government and legislative and regulatory and financial repayment mechanisms is a false distinction. Substance use disorders are a subset of mental health disorders, and mental health disorders are a subset of chronic medical conditions. And so I want to start by giving you some evidence around this, because I think most of us who work kind of in, I'll call it systemic, institutional, behavioral health settings, have this belief that mental health and substance use disorders and other mental health conditions are chronic medical conditions. But I really want to talk biologically about the evidence for that, because if we can start thinking about the chronic relapsing, remitting pattern of chronic medical conditions and apply that to addiction, and then apply that to what we see to our efforts to address racism, we'll be able to draw a thread with our skill set so that we're not starting from scratch. So we have this concept. My first slide is still showing, Pamela. It's not scrolling through the slides.
It's not scrolling.
Well, thank you for telling me before I got an hour in. So I'm going to stop sharing and I'm going to try to share a different way. To the rest of you all in the audience, y'all are like, dang, she is getting a lot of mileage out of this title slide. Let me see then. The best way for me to do it, I think, is to try to do this. Now, what do you see? Nothing?
Nothing.
Okay. This is quite the, oh, my PowerPoint crashed. That's why. Starting again. Okay, starting again. Perseverance wins the race. I'm gonna present. Okay, that'll do. And then I'm going to share PowerPoint. All right, do you all see my slides?
Yes.
And you can see the big slide and you can see what's coming up, right?
Right.
I'm gonna try to just show you only the big slide, but if that doesn't work, I don't mind y'all seeing what's coming up as long as you can see. So let me see, I'm gonna try to do like this. I'm gonna try to do like this. I'm gonna try to do like this. You can see my first slide. Can you now see addiction is the epitome of disconnection?
No, it's still the well, we can see it over to the side. But you know, in the middle, the large side is your very first slide.
Yeah, the presentation is not working on PowerPoint for whatever reason. So we'll do it like this. Okay, now you see addiction is the epitome of disconnection.
Yes.
This is where I actually spent all my time, right? Oh, I can try to use presenter view. We can see if it'll work. Can you see epitome of disconnection? Yes. And I can still see the chat box. Thank you. Thank you, Erica Persall, for your technical support here. So talking about heritability with addiction as chronic medical conditions. Heritability is a concept we have in medicine. You may already know about it. We know that every chronic medical condition has biological and psychosocial inputs. So this nature versus nurture argument, to which the answer for every illness is yes, nature and nurture. And so we measure this heritability coefficient, which tells us what percentage of your risk for developing this illness is coded in your DNA the day you're born. You inherited it from your parents. The remainder of which then of your risk for developing that illness has to do with your early life experiences, psychosocial, environmental factors. When we look at heritability coefficient, we measure it from 0 to 1. You can think of that as like 0% to 100%. And the higher, the closer we get to 1, the closer we get to 100%, the more your risk for that illness is coded in your DNA the day you're born. You were, like they say, you got it from your mama. You were born with it, it's in your DNA. So when we look at heritability across these chronic medical conditions, the way we measure it often is with twin studies. So we'll take identical twins who are genetically have the same DNA, fraternal twins who are really just brother and sister that came out of the womb at the same time. So they have the overlap of DNA that a brother and sister would. We take those twins and we have genetic twins, identical twins who were raised together, identical twins who were separated. We look at what percentage of each of them developed whatever illness we're looking at. And the more heritable, the higher the heritability coefficient, the more percent of twins, even if they're raised in two different environments, will both develop that illness or both not develop that illness, because it's really being driven more by DNA than by environment. The closer to 1 the heritability coefficient is, the more this illness is programmed in your DNA, the less environment is exerting on your risk for developing this illness. So if you take a look at this chart, you see addiction has heritability coefficient. This is a amalgamation of studies, right? Between 34 and 61%, 0.34 to 0.61. Asthma as an adult, 36 to 70. Diabetes type 1, 30 to 55. Hypertension, which this is essential hypertension, so regular high blood pressure, 25 to 50. So let me make sure I understand that you all understand this concept. Use the chat box for me. Looking at these heritability coefficients, which of these chronic medical conditions has the highest genetic loading? The highest percentage of your risk for developing this illness is coded in your DNA the day you're born. Asthma. Asthma, okay, you already, exactly. Asthma, right? Because asthma is topping 70 on that right-hand side. What that means is 70% of your risk for having asthma as an adult, not as a child, because it's different as a child. Environment has a lot more to do with it for the little kiddos until their airways get big enough to take environmental insults. As an adult, 70% of your risk, if we're going on the high end, for developing asthma is coded in your DNA. It's in your genes. That means the other 30% of your environment that we're trying to control, decrease pollution, decrease smog, don't smoke, reduce secondhand smoke, reduce stress, healthy eating, sleeping, all of those things that we do for general health, we get like 30% of the environment to try to control that. What is on the high end, the heritability coefficient for addiction? I see your question, Deborah. I'm going to come to it. Put in the chat box for me. On the high end, what percent? 61. 61, right? So that means 61% of a person's risk for developing addiction on the high end of this scale is coded in their DNA the day they're born. That means the 40% of environment is extraordinarily important because I can mitigate this genetic risk for addiction, 60%, with what happens in the 40% in the environment. When we're doing our initial evaluation, remember I talked about applying the skill sets that we already have for substance use disorder. When we're doing our initial evaluation, one of the sections we ask about is family history. And a lot of times when I'm teaching medical students, they think we're asking about family history, like, what was it like growing up? No, that's developmental history. I'm looking at family history because I'm trying to quantify an idea for myself. What is the heritability coefficient for this person? So when I have a person that says, I'm the first person in my family, I don't know about anybody else that ever struggled with any kind of addiction or any drugs, I'm like, okay, they're on the lower end of this heritability coefficient. Sometimes that's just because the family doesn't talk about it. But let's say actually nobody else in your family ever struggled in any way, on the lower end. When I have a person tell me my mother, my father, my brother, my sister, my aunt, my uncle, my grandfather, I know on the higher end of this heritability coefficient, which makes it even that much more important to understand what I need to do with the 40% of the environment. When we're taking this concept and we're trying to apply this to racism, this, Deborah, is where epigenetics comes in, right? Epigenetics tells us that our environmental experiences are actually changing our DNA. So being subjected to racism, discrimination, poverty, abuse, neglect, instability, lack of nurturing, incarceration, all of these chronic traumas are changing our DNA. And through epigenetics, we pass that DNA to the next generation. And so whereas this generation may have an addiction heritability coefficient of 34, you heap on poverty, instability, incarceration, racism, discrimination, marginalization, oppression, all of that epigenetics changes and increases stress in DNA and decreases resilience in DNA. And then the next generation maybe has a heritability coefficient of 40. And then you expose that generation to all of those environmental insults, chronic trauma, systemic oppression, racism, marginalization, and the next generation has a heritability coefficient of maybe 50, right? And so it is so extremely important for us to understand the impact that racism has on health today. I say racism kills fast and racism kills slow. right? So the chronic daily chipping away physiologically and psychologically at our health that racism causes, but also the epigenetic and generational risk that racism causes, because we can be intervening in that 40%. And we're going to get a little bit into it a little bit more. Thank y'all for your participation. And so the other reason it's important to make sure we understand addiction as a chronic medical condition and this concept of relapsing, remitting, and what it has to do with racism is because even though many people, like you might be able to get people to understand that addiction is a chronic medical condition, but there still is this sentiment that treatment for addiction doesn't work. I do a lot of podcasts, and I swear to you, every single podcast, it's like, how do you continue to work in addictions when people are not getting better? Some variation on that question. It drives me crazy, number one, because it is rooted in stigma and lack of understanding of this concept of relapsing, remitting. So if you look at these chronic medical conditions, this is a study by McClellan, one of our sentinel studies in addiction medicine back in 2000, where he was like, addiction performs just like every other chronic medical condition we have. That last heritability slide was from the same study. So what they looked at here was people who went for inpatient treatment for the condition in the first column, and 1 year later, what percentage of those people were following treatment recommendations, and what percentage of those people had experienced a relapse of their illness. The definition of relapse being a reemergence of symptoms after a period of time where symptoms were controlled. For addiction, 1 year after inpatient treatment, 40 to 60% of people were following treatment recommendations. 40 to 60% had had a relapse of that addictive disorder at 1 year. Okay, this is, a combination of studies. That's why there's a range. Asthma, 1 year later, 40% of people were following medication recommendations, 30% were following lifestyle. The reason addiction is not divided into meds and lifestyle is because this is 2000. The only medication we had for addiction at that time was methadone. This was not a methadone study, so there were only lifestyle recommendations, rehab, residential, sponsor, psychosocial recommendations. So that's why you don't see meds under addiction. Asthma, 40% of people following medication recommendations, 30% following lifestyle recommendations. Greater than 60% had had a relapse in asthma symptoms 1 year after that inpatient treatment. Diabetes, less than 60% following medication recommendations, less than 30% following lifestyle recommendations. 30 to 50% of people had had a relapse of their diabetes at 1 year. And do you hear the language that I'm using very intentionally? I'm not saying 30% of people relapsed, because it's not the person who relapses. The definition of relapse is a reemergence of symptoms after symptoms have been controlled, and illness relapses, right? When a woman has breast cancer and it's in remission, and then the cancer reemerges, we don't say that woman relapsed. We say the cancer relapsed. And it's super important because of the stigma and disconnection and judgment that comes with you did it, as opposed to you have an illness that is relapsing and remitting, right? So after a year, 30 to 50% had had a reemergence of their diabetes symptoms, meaning their blood sugar went up, the illness had relapsed. Hypertension, at a year, less than 40% were following medication recommendations, less than 30% were following lifestyle recommendations. 50 to 70% of people 1 year after inpatient treatment for hypertension had experienced a relapse of their hypertension. So let's use the chat box again, okay? Taking a look at this data, which one of these illnesses should we stop treating because treatment doesn't work? Put in the chat box. No, nobody's willing to choose any one of these illnesses that we should stop treating because it doesn't work. But that's how we talk about addiction, right? Treatment for addiction doesn't work. How can you continue to work in that industry? Why should people be able to come back to treatment 3, 4, 5, 6 times? They're not ready for treatment. They're not motivated for treatment. When in fact, they have an illness that is relapsing, remitting. And then here's the other question I'll ask, because I agree with you. We have to keep trying on all of these illnesses, right? But when somebody gives you the idea that they believe treatment for addiction doesn't work because people just go back to using drugs. A pharmacist just said that to me the other day when I was calling in a prescription for somebody. Then you hit them with this. Well, then do we have to stop treating asthma? We have to stop prescribing inhalers. We have to stop prescribing insulin and glucophage. We have to stop prescribing beta blockers and diuretics, because the relapse rate of those illnesses are actually higher than the relapse rate of addiction at a year. And that was before we had medication. That was when we only had psychosocial and we were not able to intervene on the biological arm. Now, let me ask you another question based on this slide. Looking at that follows treatment recommendations. Are people with addiction terrible people that don't listen to anything we have to say and otherwise their illness would be better? Which group of people with which illness are less often following recommendations? All. The answer is all, right? It's because, yeah, diabetes, Sheila, you're exactly right, okay? Less than 60% of people, well, really, no, actually, diabetes, less than 60%. Asthma and hypertension, less than 40% of people were following medication recommendations at a year, less than 30% following lifestyle recommendations. And so, should we point that at the people, or should we think about what are the medication recommendations we're making and what are the lifestyle recommendations we're making that people can't follow? Because I promise some of that 40% are not following those medication recommendations because they lost their insurance and they can't afford it, or they still have insurance and they can't afford it. And 30% are not following that lifestyle recommendation, maybe because their recommendation was go to the gym and I can't take time off of work to go to the gym. Or it was eat healthy and I have to drive 30 minutes to a place that's going to give me healthy food, whereas this place right next to me gives me food that I can eat, that I can afford, that's not healthy, right? So when we look at this, we pointed at like, oh, 60% of people with addiction don't even follow our recommendations. That's why treatment doesn't work. When really this slide tells us a different story. We have to take a broader view. And bringing racism into it here, when we look at the disparities of access, the physiological and psychological consequences of racism, you can see if this was broken down by race, we would see disparities. Just like everything we look at when we break down by race, we see disparities. And so if we think about racism, this concept of being able to follow recommendations and relapse rates, thinking about racism, right? Like the recommendation is don't be racist. That's easier said than done when we're raised in an environment where it is programmed and often like implicit, subliminal, under the surface, we don't even recognize it, right? Because if it's outside of our own experience, it can be hard for us to see. And so whereas racism is very easy for me to see as a Black person, I'm attuned to it, I'm sensitive to it, I can recognize it when other people can't recognize it because it's part of my experience. The same is not true for the experiences of a person in a wheelchair, because I've never been in a wheelchair. So I can be in an environment that is completely, utterly inhospitable and frankly, explicitly dangerous for a person in a wheelchair and never notice. And so if I set for my goal, which I certainly have a goal, don't discriminate against people in wheelchairs and don't contribute to the marginalization and oppression that people in wheelchairs experience, because we know they do. I certainly have that as a goal for myself. I will have relapses just because I need to be constantly putting my eye on trying to see something that's outside of my own experience. The way you do that is by surrounding yourself and empowering the voices of the people that are having those experiences. We're going to get into that in a minute. So this is my first foray into trying to draw the parallels between racism and addiction. When I talk about being able to use the skill sets that we already have and apply them to building racism-informed systems, one of those is the biopsychosocial model. So you all know the biopsychosocial model. We use it in all areas of medicine. It says that every illness has biological inputs, psychological inputs, and social inputs that make it develop, that make it get better, that make it get worse. It's a multidisciplinary approach that includes everybody: medical professionals, social workers, administrators, public relations and media people, family members, teachers, communities, governments. Everybody has to be part of the biopsychosocial approach. What I want you to do is expand this concept from biopsychosocial to biopsychosocial, cultural, political. And I'm adding on cultural political because we know stigma drives illness. We know illness and health disparities. We know racism drives illness and health disparities. We know discrimination drives illness and health disparities. We know marginalization, oppression drives stigma and health disparities, right? Illness and health disparities. And so if we know that, and we know that it is the rule, not the exception, that people of color in this country, people in other marginalized groups in this country are experiencing stigma, racism, discrimination, marginalization, criminalization. We know that's the rule, not the exception. Then we have to be applying interventions in that realm as well if we want to affect that column that said able to follow our recommendations, and that column that said rates of relapse of that illness, no matter what the illness is, especially addiction and other mental health conditions. And so we're going to take a little bit of time. We're going to step through biological, psychological, and then we're going to spend the most of our time on cultural, political, and move into racism as a trauma. This is our goal: to intervene in all four areas for individuals, families, communities, and systems. Let me see, Sharon. Yes, there are recordings. So just reach out to SATTC and they'll get you the recording from today's talk, as well as point you to where they're housing the recordings for the other two trainings that preceded this one. So when we look at biological, we spent some time talking about genetic and inherited today already, but biological is splitting into two arms. You're born with it, that's genetic. So that's that heritability coefficient we were talking about. Nobody is born with a heritability coefficient for racism, okay? Acquired, right? It means you got it along the way. So biologically is heritability coefficient for addiction. If we're talking about that, a biologically acquired risk factor for addiction would, for example, be the pain pills that you got prescribed after you had a serious surgery or car accident, and then you developed an addiction to those pain pills. You can see the examples that I put here. We know that depression runs in families. That's not just because you were raised by a mom who was depressed and you learned how to be depressed. It's coded in your DNA physiologically, right? We know that an acquired risk factor for depression is actually a stroke in the part of the brain that's responsible for managing our emotions. So biologically, we have to be looking at each person that sits in front of us. Biologically, what are those genetic inherited risk factors? Biologically, what are those medical or acquired risk factors? How do I intervene? So the way we intervene for substance use disorders biologically right now is reduction and cessation of substance use, medications, whether that's Suboxone, buprenorphine, naltrexone, methadone, treating other mental health conditions, depression, anxiety, trauma, treating other physical conditions, diabetes, asthma. That's the way we're intervening biologically, okay? We're going to draw a full circle when we talk about social, cultural, politically with epigenetics, which brings us back to biology. Let me just spend a minute talking about the neurobiology of mental health disorders, including substance use disorders. And this is also the biology of racism, okay? When we look at the main systems in our brain that are responsible for thinking, feeling, decision-making, and behaviors, it is our limbic system and our dopamine system. The dopamine system, you've known it, you've heard it called the motivation pathway. You've heard it called the reward pathway. Okay. The limbic system is definitely implicated in mood disorders, anxiety, ADHD, psychotic disorders, PTSD, all of the mental health conditions that we have. The dopamine system is certainly more implicated in addictive disorders and psychotic disorders. This is a picture. So when you look at the limbic system, these are the main 6 structures that are making up that system. Starting at the bottom, olfactory bulb, that's your sense of smell. This is the most powerful provocateur of memory that we have. And so when we think about people being triggered, we usually think about people, places, and things as triggering risk for relapse to addiction. Smell is a huge trigger, right? It's one of those things. The hypothalamus and the thalamus, so the second from the bottom and the second from the top, are 2 structures. I say the brain and the body share the same chemicals, but speak just a little bit different languages. And so the thalamus is translating messages from the brain throughout the body, and the hypothalamus is bringing information from the body to the brain to interpret what that means. And so this is why when you get anxious, your heart races, right? You feel anxious, limbic system sends that information through thalamus sends it through hypothalamus, translates it to all of your organs. Your heart races, you breathe a little more shallow, your stomach gets queasy, you get butterflies, right? Like that's the mind body or the brain body connection through the thalamus and hypothalamus. This is also why cravings are not just thoughts. So people will tell you that craving is a full body sensory experience. That's through thalamus and hypothalamus. Amygdala and hippocampus are our memory structures. Hippocampus is your factual memory. Amygdala is your emotional context for those memories. Very, very implicated in fear, anxiety, okay? And so I always say, like, you see your ex whoever, and the hippocampus is like, oh, eyes right there, nose right there, mouth right there, skin color, that tone. That's ex whoever. Amygdala is like, that's ex whoever, and all the emotions that come along. Or, oh, that's the one that got away. That's ex whoever, right? Amygdala is going to give you that contextual memory. When you think about racism and its impact on us, these are the same structures, right? So when I'm in a place, I was actually in Boston. This was before the pandemic. No, actually, it was my first trip after the pandemic, May, several months ago. I was in Boston. I stayed in an Airbnb. I was walking to the corporate office. And I'm walking down the street, and it's a beautiful morning. I'm just like loving life. It's a residential area. And there was a man on the front desk of his porch. White man, looked fine, like not looked like a nice guy, whatever. So I'm walking by, and so I looked at him and I smiled and I was like, good morning. And he just gave me a steely stare. Now, that could easily have just been the difference between me being from Indiana, where you look people in the eye and say hello, and him being from Boston, which Northeast culture is different, right? Like you mind your own business and don't talk to strangers as a cultural big brush to draw. It could have been that. What it triggered for me, my limbic system, that amygdala sent to me when I had been in dangerous situations in Indiana growing up, when I was the only Black person on a street by myself with a white man giving me a steely glance, and it turned into a dangerous situation. Triggered in the instant, right? From beautiful walking down the street, enjoying a lovely day, to suddenly I was in fight or flight mode and fearful, with my heart racing, shaking a little bit, feeling like, let me get off of this road quickly because I don't know what this man's intentions are, right? And so that amygdala threatens the relapse, because even on the other side, maybe everybody is practicing anti-racism, but we get these unconscious implicit triggers then that can force us to relapse back to behaviors that we had before, because this part of our brain can run on autopilot. Very importantly, the limbic system and the dopamine pathway are in our deep brain, can run without us, can do absolutely everything, protect us from danger, control our behaviors, all of that. without it ever rising to the prefrontal cortex where we grab consciousness of it. I know each and every one of you has driven to work, and you got to work and you were like, oh man, how did I even get here? I was somewhere else for that whole commute, because your deep brain can do that for you, right? And so when we think about applying what we know about the neurobiology of substance use disorders and other mental health disorders, it applies to what we know about racism, because racism is running through that limbic system. And in many ways, racism is a survival mechanism that's running through the dopamine pathway. So looking through the dopamine pathway, whoops, sorry. I clicked and hit the button at the same time, so it gave me 2 slides going forward. When we look at the dopamine pathway, this is the dopamine pathway, again, in the deep brain. 3 neurons, starts in the ventral tegmental area, that VTA, feeds forward to the nucleus accumbens, finally lands on the prefrontal cortex, where you can grab conscious control of it, although you don't have to. And the dopamine pathway, the motivation pathway, is saying, you need this to survive. That's the evolutionary responsibility of the dopamine pathway. VTA tells nucleus accumbens, prefrontal cortex, we need this to survive, make a plan to never go without it. And so the natural determinants of food, water, sex, nurturing, those give us dopamine signals because we need them to survive. We need them for the species to propagate. Drugs give a supernatural dopamine signal. And so when you get a supernatural dopamine signal, the brain interprets a bigger dopamine signal as more important, period. And so the drug becomes more important than food, water, sex, nurturing. I hate this phrase, drug of choice, right? The brain is choosing it because the dopamine signal is bigger. So if you've known someone who chose food over sex, drugs over food, drugs over water, drugs over sex, drugs over their family, that's the nurturing symptom, right? That is because the size of the dopamine signal of methamphetamine is like 10 to the 9th, the size of the dopamine signal of giving a hug to someone. When we look at racism and you look at dopamine's messages, you need this to survive, we have built social constructs that give the dominant population, cisgendered, rich white men, the belief that they need racism to survive, that there is not enough pie for their needs to be met if the needs of everyone else is being met. And so it starts that in that psychosocial construct, psychosocial, cultural, political construct, then becomes biological, a dopamine signal, a sense of threat through that amygdala, the prefrontal cortex being responsible for building and designing systems that resolve the threat that my needs will be stolen by someone else, right? So when you hear those arguments against, like way back in the day when you heard those arguments against affirmative action, and it was whites will have their seats stolen by Black people who are not as qualified. That's running through the dopamine signal. And so when we started at the beginning and I said we had addiction, continued behavior despite negative consequences outweighing positive benefits, the belief is that the benefit is I'm protecting what's mine. If we can't undermine that belief and or build structures that make it clear that actually everyone can thrive, then we're driving the perpetuation of the behaviors of racism, which clearly have negative consequences. I see Scott asked me a question, what about the in utero impact of racial trauma? That is epigenetics all the way, right? It's actually upstream from epigenetics. So we know that everything a mother sees is translated chemically through the umbilical cord, through the placenta to the baby. And so, yes, there actually is a literature that shows us premature, preterm birth, smaller birth weight with everything else controlled for except racism. The impact is real and is quantified. This is the last thing. I just want to talk to you about how powerful those deep structures are. This is a study done out of the UK. Sorry, I didn't put the reference down there. This is a study done out of the UK for people who are in recovery from cocaine for 20 years. They put them in the MRI. And in the MRI, they showed them nature videos. And you can see the amygdala was like, whatever, boring. We remember amygdala is giving emotional context. They put the groups in and showed them people doing lines. This is 20 years abstinent from cocaine. And that amygdala is on fire. Full body craving, sends it, hypothalamus, thalamus, prefrontal cortex, you remember. And they had to stop the study early for safety because of the severity of cravings that people were having that they knew was driving a risk for relapse. This is what happened to me on that Boston street. When I was just walking around being friendly and that guy was like, hey, sir, how you doing? And he gave me that steely glance. My amygdala fired and took me back to all those experiences that have nothing to do with that man, right? Like he didn't do any of those things, but it went through hypothalamus and went through thalamus and went to prefrontal cortex and said, this is dangerous. Get out into an open space where there are other people. And so that amygdala is always at work. That limbic system is always at work. That dopamine pathway is always at work trying to keep us safe. And so if we can figure out what the dopamine pathway is trying to help us use to survive as part of that addiction of racism, and we can get to that through other means, then we can start undermining the behavior of racism and the negative consequences that come from it. Finishing biological, moving to psychological. Psychological is the way a person views the world. This comes from our experiences based on childhood, early adulthood, adolescence. I put those out of order, but you know what I meant. And then as we turn into adults, what we do is take the experiences that we're having and confirm our beliefs that have already been formed. It actually takes an explicit, active effort to have a new experience undermine something we already believe. And so we have to be making that explicit effort, right? So if we already believe that treatment for substance use disorder doesn't work, or we already believe that people who look like this won't help, or we already believe that Black men are angry and violent and dangerous, even if that's an implicit belief programmed by media, like we don't have to explicitly believe it. As we're having interactions as adults, we're filing those interactions into the file cabinets that already exist. Yep, that reinforces this. Yep, that reinforces this. And so this is the 40% on the other side of that heritability coefficient that is extremely important as we're trying to, for the younger generation who's coming up, mitigate the risk of developing a substance use disorder in the first place. And for those people who are getting in recovery, mitigating the risk that that illness will relapse. You already know one of the main predictors of who develops substance use disorder is trauma, because we're taking that heritability coefficient, that 40 to 60%, and then the 60 to 40% we have to manage in the environment, trauma, compounding that genetic risk. We know that trauma at an early age increases the risk of should say use, because abuse is a crime and substance use is not. Well, it is, but political commentary aside, we shouldn't be diagnosing things like as if they're crimes. So that should say substance use. I will update that later in life. Substance use is associated with an increased risk for experiencing trauma. So this is bi-directional. Clicking down from kind of the concept of severe trauma to early adverse childhood experiences, the ACEs, we know any score of more than 4 out of these 10 is driving a risk. And I put, because we're talking about substance use disorders, that's why I chose these 3 boxes. But these 3 boxes could be stroke, heart attack, asthma, low birth weight, maternal mortality, cancer. All of the studies show that adverse childhood experiences score 4 or more predicts all of those illnesses. Now, adverse child experiences study was done in a predominantly white population. Still applies, but I promise you we could add a box there that says racism, because racism is absolutely, we know through the weathering literature, driving all of these as well, an experience of racism in childhood. Those with ACEs scores of 4 or higher are 20 times more likely to be incarcerated at some point in their lives. 20 times. This is the criminalization of mental health and substance use disorders. And that criminalization, remember I said we have to talk psychosocial, culturally, politically, feeds back, because look at what one of these ACEs scores is, incarcerated household member. So the point at which we incarcerate that parent who has an ACEs score of 6, we start their kid out with an ACEs score of at least 1, never mind whatever else they experienced on this screen. Just bringing home the social, cultural, political point, and I'm going to do probably a couple of more slides on this, is looking at the risk of arrest for Black Americans by complexion. We cannot close our eyes to the social, cultural, political impact of racism on health. Purely the darkness of my skin predicts my risk of being arrested. Everything else controlled for. So you can't tell me that just because I'm very dark, I'm committing more crimes, right? I am perceived that I will be committing more crimes because I am very dark. And then think about the psychological and physiological ramifications of being arrested, on top of the psychological and physiological ramifications of the racism you've already experienced your whole life. This is a real phenomenon that we have to be able to put our eyes around. This is the last thing I'm going to spend on this, then we're going to get into racism as trauma a little bit deeper. Prior to the 1870s, this is like me making my case on why social, cultural, political is important. Prior to the 1870s, there were no illegal drugs. There were drugs, but nothing was illegal. And what you can see from this timeline, and I read this slide directly from at Eleanor Health, every single one of our new staff members, whether you're in direct care or administrative, doesn't matter. Every single person goes through a training called Cultural Oppression, Racism, and Recovery. And I lifted this slide directly from that training. And the point of this slide is that there is no separation between racism and illegality of drug use in this country. They are one and the same. And so what you can see, before 1870s, there were no illegal drugs. In 1870, the first laws making drugs illegal were anti-opium laws, and they were specifically to target Chinese immigrants, with the goal of incarcerating Chinese immigrants so you could say you have been convicted of a crime so that they could be deported. Racism. The next set of laws were anti-cocaine laws in the 1900s, targeting Black men in the South. This is as freedom is starting to become a thing from slavery, and it is a way to keep Black men enslaved. There's literally, to this day, the 13th Amendment says you can make people work for you for free. You own them as long as they are serving time for a crime. Today, that persists in the 13th Amendment. 1910 to 1920, anti-marijuana laws were targeting Mexican migrant and Mexican Americans, again, with deportation goals. In the 1960s, Nixon launched the war on drugs. He has a quote that says, "The war on drugs was targeting Black men, hippies, and anti-war. We knew if we could criminalize Black men and disrupt their communities and make hippies look violent, then people would vote for us." By the 1980s, these laws began to have the effect that they were intended to have. So 50,000 people were in jail any given year for nonviolent offenses. By 1997, 400,000 actually per night. By 2019, 451,000 people in jail every night for nonviolent offenses, mostly related to substance use disorders, overwhelmingly people of color. And so when we think to ourselves that we can divorce social, cultural, political things, like that's outside of health, that's not our jobs, that's inside of health. That's our jobs, because all of this is affecting who develops substance use disorders, right? Like whose heritability coefficient are we exacerbating with environment, and who's getting access to care, and who's getting what kinds of outcomes after care. So this is the first where I want us to apply what we already know to the concept of racism so we can start designing more racism competent systems. These are the national principles of care for substance use disorder treatment. And if we replace, these are all, the concept is like substance use disorder treatment. If we just replace that with racism, look at what we get. Routine screenings for racism in every medical setting. A personal plan for how to mitigate the effects of racism for every patient. Fast access to treatment for the impact of racism on your health. Long-term management of the impact of racism on your health. Coordinated care to address the impact of racism on your health. Behavioral health care from legitimate providers who understand the impact of racism on your behavioral health. Okay, we're not going to give medications for racism, but we want to give equitable access across race and ethnicity demographics for addiction treatment, which we don't currently have. So Black people are up to 35 times less likely to receive a prescription for Suboxone when they have an opioid use disorder and have been seen in the ED. Support for recovery outside the doctor's office. If we could apply these 10, it's not 10, 1, 2, 3, 4, 5, 6, 7, 8 principles that we already try to adhere to and just apply those with a specific intent to make sure we're addressing racism at each one of those 8 levels, we've already started to make meaningful impact on the inequity that Black people see in our behavioral health and addiction treatment systems. And so thank you, Aboriginal, Indigenous in my timeline. Thanks, Stephen. I will pull that out. I don't know of a law that was specifically enacted against Indigenous Aboriginal people in terms of making drugs illegal, but I will certainly look at it. Thank you for putting that on my radar. So bringing home this concept that racism is trauma and then rolling into, and so how do we use our understanding of trauma-informed systems to be building systems that can be more effective for Black folks? I want to lay down this concept, and if you are in the first and second parts of this series, you've seen it already, racism as a chronic and acute on chronic trauma. So in the lives of Black folks, and certainly other racial demographics, Hispanic, Native American, Indigenous, Aboriginal, Middle Eastern, Asian, racism is a chronic cumulative trauma. It's pervasive, it's invasive, it's every single day. The rule is that I will have an experience with racism today, not the exception. And so when we have events like the killings of Breonna, Ahmaud, George Floyd, Rayshard Brooks, those are acute traumas that overlay and trigger the chronic ongoing trauma of the pervasive, invasive, traumatic experience of racism. I want us to watch this video, and this might pop us out. And if it does, I know I'm going to have to share the screen a little bit differently. So apologize for what I anticipate are technical difficulties coming up. I want you to watch this, and I want, if you've been in the other sessions, you've seen it. I want you to type in the chat box your reaction, thoughts, feelings, physical symptoms, right? That whole limbic system, hypothalamus, thalamus, prefrontal cortex, physiological, psychological. I just want to see your reactions. And actually, just because I anticipate that's going to give us a problem, I'm just going to go ahead and practice an ounce of prevention. Just here. Oh, it appears I practiced an ounce of prevention, but my ounce of prevention was ineffective. You all still see racism and oppression equals trauma on the screen? Okay, great. Sorry, I have 2 screens and I obviously can't tell what y'all are looking at and what I'm looking at. Here we go. It is here. You see a YouTube video? Great. Thank you, Cheryl. I can see you nodding your head. Out of all 200 people on this call, you're one of the 4 faces it's showing me. Here we go. Type your reactions in the chat box. What did you feel? What did you think? What physical sensations? Goosebumps. So you can feel people doing everything to get their point across, to be seen, heard, felt. Sadness makes me want to cry. Heavy, loaded, so saddened. Sadness, powerful. Emotional, chills, sad. So that physiological reaction, I'm going to get back to my PowerPoint. That physiological reaction is a trauma reaction. It's a fight or flight reaction. It's a survival reaction. And so I use that in case there's anyone who's not exactly sure it feels right to draw the equality, the equal sign between racism and trauma. Like you can hear the lump in my throat. It's interesting. I show this video a lot, and I went through a period of time when I was really sensitized to it, where I actually couldn't watch it. So I would stand here, but I wouldn't actually watch the video. But the music sensitized to me. And then I got to the point, which is where I am now, where I watch it, but all I can see are the names. I can't see any of the images behind it. And I always come out with this really visceral reaction, like I feel a little bit like I'm gonna cry. And so when you have the pervasive, invasive experience of racism every day, and then we have events like this, and this was back after George Floyd was killed. And so the hundreds of names actually that can add to all of those names that we saw that have been killed since then, we have to pay attention to it. The psychological burden, the physiological burden is driving the health disparities that we see. Oops. All right, now y'all know I have no idea. Oh, okay, I can see. I was about to say, y'all know I have no idea what is on your screen. So when we think about then trauma-informed care, what trauma-informed care, and this is a concept all of us have been trained in, and in the last 20 minutes, I want us to do some work together. It's an approach that assumes an individual is more likely than not to have had a history of trauma. I want to, everywhere we see the word trauma, replace it with racism, right? Racism-informed care is an approach that assumes an individual is more than likely than not, an individual of color for sure in this country, to have had experienced a history of racism. And so as a racism-informed organization, we recognize the presence of trauma systems as a result of racism. We acknowledge the role that trauma as a result of racism may play in an individual's life, including our staff. And I think a lot of times that's where we forget that the people who are doing the work are also traumatized by racism, and that we have to create these systems that take care of not just the people we're caring for, but the people who are doing the caring. And so if you look at SAMHSA, SAMHSA gives us 3 E's, 4 R's, and 5 guiding principles as it relates to building trauma-informed systems. And so these are the 3 E's. This is just me driving home. I'm like the prosecuting attorney trying to convince you of my case that racism equals trauma, right? This is the definition of trauma. 3 E's. Individual trauma, results from an event, series event, or set of circumstances that is experienced as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the functioning and mental, physical, social, emotional, and spiritual well-being of people. Do you feel like, just give me a yes or no in the chat box, this applies to racism? Is racism a series of events or circumstances? Is racism experienced as physically or emotionally harmful or life-threatening? And does racism have lasting effects on the functioning mental, physical, social, emotional, and spiritual well-being of people? Yes. Angie says, absolutely, right? Not one person putting no in the chat box. It fits. And the beauty of it fitting is that means we can use what we already know about trauma, okay? Trauma is almost ubiquitous among a male prison population, rates of exposure between 62 and 100%. So our folks who are being traumatized are going to prison and then being traumatized again. Just like trauma is ubiquitous in a male prison population, racism is ubiquitous in a Black population, in a population of color. And so if we accept that trauma, that racism meets the 3 E's of trauma, then that means we take the responsibility to design systems and treatment programs that employ the 4 R's of racism informed care, understanding that racism equals trauma. So I can call it trauma informed, I can call it racism informed, racism being a specific type of trauma. The 4 R's that SAMHSA gives us are: 1, we have to realize the widespread impact of racism and understand the potential paths to recovery from racism. 2, we have to recognize the signs and symptoms of the trauma of racism in clients, families, staff, and others who are interfacing with our systems. 3, we have to respond by fully integrating knowledge about racism into our policies, procedures, and practices. And if you didn't attend the second session of this series, it was called Pursuing Organizational Readiness, Laying the Foundation. We went through some very specific, concrete tools and strategies that you can use to one, assess your readiness for racial equity in your system, but 2, to begin fully integrating knowledge about the trauma of racism into your policies, procedures, and practices. And then finally, we have to resist re-traumatization. So I pulled this from a child and adolescent source, which is why it says of children. We have to resist re-traumatization of everyone, as well the children, the adults who are being cared for, who are doing the caring, basically clients, family, staff, and others who are interfacing with our system. And so if we agree racism fits the 3 E's of trauma, we hold ourselves accountable to employing the 4 R's of a trauma-informed care system as it relates to racism. Let's double click just a little bit. I'm going to take realize for granted the widespread impact of racism, although I won't take for granted understanding the potential paths to recovery. That's like a whole webinar on its own. I'm not going to take for granted recognize, because I think often we misinterpret the symptoms of the trauma of racism to be unjustified anger, aggression, entitlement, lack of compliance, lack of motivation, lack of readiness for treatment, like all of these monikers that we put on it when it is actually a reaction to the trauma of racism. And so I'm not going to take that for granted, because we could also do a whole nother webinar on that. But for time's sake, I'm going to go to respond and resist re-traumatization to double click. Oh, actually, I guess I'm going to go to recognize. So in recognizing, these are the classic symptoms that we use to make a diagnosis of PTSD to define the reaction of trauma. When you look in complex psychological trauma literature, we know that it shows in many different ways: relationships, housing instability, job instability, for adolescents getting in trouble at school and dropping out, legal problems, right? And so when we look at all of the symptoms that we conceptualize as being symptoms of substance use disorder, I want you to start taking a broader lens. 1, having the conversation. And again, I encourage you to watch parts 1 and 2, where we specifically talk about how to open this conversation in an individual clinical context. But what is the impact that racism has had on your health? And you will start to see that many of the characteristics that we assign to the addictive personality are actually reactions to the trauma of racism and oppression. I'll tell you a story about the people we take care at Eleanor Health. We call them community members, because we're trying to build community at Eleanor Health as opposed to just be like a provider of services. And so I was seeing a community member a couple of weeks ago for an initial psychiatric evaluation as part of his care with us. And he looked white to me, right? So looking across the screen, he looked like a white guy. We were talking, we were having a good time. So then I started to move into the social developmental history, and I always open that up with a very wide question for people. I say, talk to me about your childhood, who was around, what was it like? And the very first thing he said was, because I was the only off-white kid in my neighborhood. And then I had to check my own, right? Because I've been operating under the assumption that this man is white. Not that that means I know anything about him, but my implicit bias makes me think I know something about a white guy from Ohio, right? So he says, because I was the only off-white kid in my neighborhood, I suffered relentless racism. They called me tar baby and threw rocks at me and wouldn't play with me and wouldn't invite me places. And that gave me a lot of depression and anxiety as a kid. I still deal with it today. This man is 61 years old. 61 years old. I asked a very broad, tell me about your childhood. And the top of mind formative experience from his childhood at the age of 61 was racism. And I wouldn't have even asked him about that because he looked white to my eyes, right? So that's going back to this concept of the racism informed system assumes that everyone has had an experience with racism. If you make that assumption and we make it part of our universal screening, what is the impact racism or discrimination has had on your health? It opens up an entire new set of support that we can provide folks. Resisting re-traumatization is extremely difficult to do because there are so many triggers all day, every day. Microaggressions being a big part of that trigger pie. But this is a doc that I really respect. I encourage you to follow her work. This is her Medium account, Dr. Jessica Issam. And she just recently reposted this article. It's from December 2020, but she just recently sent it around. And I thought it was really important when anti-racism becomes trauma. As you are building anti-racist treatment programs, systems, organizations, as you're building racism-informed care and systems, that fourth, avoiding re-traumatization, resisting re-traumatization, is extraordinarily, crucially important, right? And so this is the quote that she put. She was actually going into a DEI meeting at work, and she put, she had been in this moment before, and she knew that this was an invitation to speak on racism would stir up a trauma response that white racial others rarely recognize. She knows that many of these meetings have harmful impacts, though they are well-intentioned. She knows that good intentions do not make the re-exposed wounds hurt any less. She knows that my scripted role requires self-harm to occur in service of aspirational goals for an anti-racist reconstruction of racist structures. She knows I do not have a real choice in the matter, for there is much work to do to reimagine anti-racism in the field of medicine. And she is herself. She's talking to herself in this piece. And so I just want us all to be extraordinarily aware as we are asking people to do anti-racism work, you are asking them to re-traumatize themselves. And so as you're building systems, and you know, the way through the trauma is through the trauma. And so as we're building systems, ensuring that you're putting those safety mechanisms in, those compassion mechanisms in, raising the awareness of the type of work that you're asking people to do, and trying to create environments that make it safer and easier to do that work. And so one of the things we know is that when you're doing trauma work, you don't jump straight in, right? You start with grounding and physiological regulation. You start with creating a safe space, physical safety, emotional safety, social connections, people you can trust. And then you give time for grounding and physiological regulation. And then you jump into action with the goal being to empower survivor voices and to engage allies to booster that power, but not to take over and to think that you are that power. And so as you're designing your systems, as you're trying to think about how do I decrease disparities in behavioral health and substance use disorder care for African American and Black populations, one starts with the space. Do I see people? Are our voices at the table? Is there physical safety here? Is there emotional safety here? Can I make social connections here? Two is time. This is not a sprint. I say this is a marathon followed by a marathon, followed by a marathon, followed by another point two, right? Take the time. And when there are those acute re-triggers, those acute on chronic triggers, you have to start back at number one. You're not at action anymore. You're back to making sure this is a safe space as much as we can. You're back to allowing time for grounding and physiological regulation. And then you're back into action. So it's like the stock market with fits and starts, always aiming for that trend to be up. We'll end here, and this is where I want you all to help me a bit in the chat box with some comments. Hold on, let me see what E. Hollander says. One other factor doesn't often apply. Sorry, I just realized you said that to me, so I will read it without calling your name. Yes, assessing and addressing racism in those. There's a degree of racism in all of us. That's exactly right, especially if we've been raised in this country. And I always am very conscious to say, like, I'm talking about the United States of America. That's what my experience is. I know there's racism around the world. It manifests in different ways, but you're exactly right. If you are born and raised in the United States of America, there is no way that you haven't been programmed implicitly. Even if your explicit intention is not to have racist behaviors, implicitly, we have all been programmed. And so there's no way that we're not able to do that. So ending in our last few minutes on these five principles of trauma-informed care. Remember, I said 3 E's, 4 R's, 5 principles. So these are 5 principles of providing, designing trauma-informed care: safety, choice, collaboration, trustworthiness, empowerment. What we know explicitly is that all people with substance use disorders, the way we have built our systems, they are not systems of safety. You can go to a 3-day detox for a chronic medical condition and never be connected to care. They are not places of choice. We think you have an addiction because you make poor choices, and so autonomy is out the window, patriarchal, telling you what to do. It's not collaboration. You don't come in and say, this is what I need. You come in and we say, this is the program we have. It's not about trustworthiness, right? We don't believe you. We're constantly checking to make sure you're not lying to us. We tell you what we need you to know. It's not about empowerment. It's about you doing what we say. All of that is the reason why, in general, in substance use disorder, we're seeing poor outcomes, and behavioral health otherwise, we're seeing poor outcomes. Layer on top of that, racism, the trauma of racism, right? Certainly we're not designing for its safety as it relates to racism. Choice, collaboration, trustworthiness, empowerment. And so when we look at the definitions of those, safety is physical and emotional. Choice, the individual has choice and control over how they receive the services that we have to provide. Collaboration, making decisions together. These are the options. This is what we can offer. This is where you would get from somewhere else. This is the evidence base we know about it. Here's what I would recommend, but based on your priorities and your goals and your needs right now, let's make this plan together. Trustworthiness, interpersonal boundaries, right? That's like that meeting that Dr. Issam was just explaining, or when after George Floyd was recently killed and the big movement towards racial equity was kicking off, several people emailed me and said, we're having these listening sessions at work where they want Black people to share our experiences of racism. That was a very dangerous environment with people they don't know, so there's no trustworthiness, right? Not thinking we're empowering you to tell your story, but in reality, we're telling you to tell your story, whether you're ready to do that or not, whether that's how you want to navigate it or not, right? And so we have to be really conscious about how we're trying to enact these 5 principles. Looking down at the bottom, safety, common areas, welcome, privacy respected, choice, individuals provided clear and appropriate messaging about rights, responsibilities, collaboration, are involved from the ground floor. This is not just the people you're taking care of. This is your staff, right? Making sure Black voices, voices of color, LGBTQ voices, immigrant voices, English as a second language voices, people with disabilities voices. If you're trying to design for equity for a marginalized group and you don't have more than one person representing that group in a position of power, you're falling down, right? Trustworthiness. I have to see people with my same values like me, my same experiences that can understand me, and then empowering and lifting up my voice. And so using the chat box, we only have about 4 minutes left. What are some ideas you all have for just one thing you can do? And using this can use as a guide, 3 E's, 4 R's, 5 principles as a guide, but also just these questions, thinking about even just one policy or one procedure where you work. Who does it help? Who does it hurt? Is it considering the biology, that heritability coefficient, epigenetics? Is it mitigating or exacerbating the psychological impact of racism? Is this policy developed from a position of privilege? Were Black voices in the room? Who does this unintentionally marginalize, stigmatize? Does this policy reduce or increase the risk of ACEs? Think of just one policy, one procedure. Type in the chat box for us, because this is a little bit of a commitment for you to walk out of here and put what we've talked about today into action so we can have butterfly effect. One policy, either at your place or that you've heard of other places, that based on this concept of racism-informed system, trauma-informed system, recommended substance use disorder treatment principles, you recognize we could be doing this differently. I'm going to say the one I already said, which is inviting Black people to race listening and putting them on the spot to share their experiences of racial trauma in mixed groups. COVID policies, epigenetics. Thank you, Doris. Thank you, Erica. What else? Just one thing this has you thinking about. Quality and reliable translation services, yes. Dress uniform policies, yes. Creating and using culturally specific scales and curriculums, yes. Hiring policies, 100%. Also firing policies. Expecting people to share all their business before establishing a relationship. We are literally, like, insurance requires us to collect deep information about trauma in the initial intake. That is so unfair. That is so unfair to people. Promotion policies, 100%. I was working with another organization that said, our employees think that we have discrimination in our disciplinary processes, but we don't. And I was like, oh, you do. Just that blind spot came out like that. You definitely do. So 2 minutes left. Thank you so much for your time. Critical race theory, compensation for emotional labor and equity work, ongoing training. Exactly. It's not a sprint. It's a long game. Any questions you all have for me in the last couple of minutes, stick them in the chat box. I'm going to stop sharing my screen. That said questions and discussions. That's what I just opened it up for. Any questions, any thoughts? Thank you. Thank you for the positive feedback. I think the recording will be available. I hope you grabbed onto something tangible that you can at least just go tell one person about. There are 80 of you still left. So if you tell one person, that's 160, and they tell one person, that's 320. And then the law of exponents applies thereafter.